Okay, welcome back. So now we'll make things a little bit more difficult. I would like to introduce with you the challenge of semiology in diagnosing seizures in the newborn, the importance of the precise characterization, the importance of using the correct terminology, because this is our language and we should be precise when we define the seizure and seizure type, and tell you about the new possible strategies for treating seizures in the newborn. We want to recognize seizures, and this is what we talked yesterday with Linda De Vries and my talk. Correct terminology will lead to the correct diagnosis and the appropriate treatment, and we will see as some babies, they won't go with protocols and they will need a tailored treatment. This is, I think it's important for me, and you will see how I was telling you yesterday, if you call me in the middle of the night, you want to be sure that you use the correct terminology in defining what are you seeing. So the objective is to provide information about the correct terminology and characterization of seizures, to differentiate acute seizures from neonatal onset epilepsy and epilepsy syndromes, and to understand the implication of diagnostic accuracy for patient management. So my big point, and you will see it through my lecture, is that neonatal seizures are generally considered as a whole, but they are definitely not. And for those who are child neurologists or epileptologists here, shouldn't be difficult to differentiate a child with a benign Rolandic epilepsy from a child, and a child with absence epilepsy from a child with severe form of epilepsy, such as Rasmussen encephalitis or Lennox-Gastaut syndrome, Sturge-Weber, and catastrophic progressive myoclonic epilepsy. Just defining all these children as having seizures doesn't provide us more information and help than saying that a child has fever, independently from if the fever is due to a viral illness, a banal viral illness, or a malignancy, or a life-threatening bacterial infection. So while the majority of seizures in the neonate are occasional seizures, they do not require the diagnosis of epilepsy, and they occur as a reactive event to acute insults, HIE, stroke, meningitis. However, a significant percentage are the first symptom of epilepsy that can be diagnosed already in the neonatal period, and that support the choice of a long-term treatment. And in some cases, seizures can be viewed as one of the signs of an epileptic syndrome. So we said yesterday, first things, when we see a strange movement in the newborn, is this an epileptic seizure? If yes, is this an acute seizure, or this is the beginning of an epilepsy? Or even more, this is a part of an epileptic syndrome. So the challenge of precise characterization. There are a lot of words that I don't like. One is subtle seizure. You say to the parents, you know, your child has subtle seizure. They say, oh, fine, it's just subtle. But subtle seizure most commonly are associated with very important brain injury. So subtle seizure doesn't really mean a lot. Generalized tonic-clonic seizure, in most of the charts, coming from neonatology units, babies who have seizure, they have generalized tonic-clonic seizures. And this doesn't exist in the newborn. This is a paper that was published on Annals of Neurology in 1985 about seizure and cerebral infarction in the full-term newborns. Those seizures were determined by clinical diagnosis without EEG confirmation, and those are the 7 patients published on Annals of Neurology. At that time, it was really easier. Patient 1, right focal motor tonic-clonic seizure. Patient 2, generalized seizure. Patient 3, generalized seizure. Patient 4, focal tonic-clonic seizure. Generalized tonic-clonic seizure, and so on. But the important thing is that they conclude that stroke should be considered as an etiology for all type of seizures, and then repeated CT scan at that time should be obtained in all the cases. And then there was a nice reply by Eli Mizrahi saying that very elegantly that generalized tonic-clonic seizures are actually not seen in the neonates, that focal tonic-clonic seizures have not been demonstrated because focal tonic-clonic seizure is a term that doesn't exist. You cannot have a focal tonic-clonic seizure, even in the older child and the adults. And most importantly, unifocal clonic seizure, rather than generalized, are most often associated with stroke, as you saw yesterday. The first proposal for the classification of epilepsy and epilepsy syndrome, published in 1989 by International League Against Epilepsy, classified neonatal seizure among epilepsies and syndrome undetermined whether focal or generalized, which means, in 2 words, I don't know what it is. And they just pointed out that they differ from older children and adults, and most of them are subtle because the clinical manifestations are frequently overlooked. We have come a long way since then, because the last 20 years have seen the development of methods such as video EEG recording and polygraphic EEG recording to document seizures in the neonates. And so this is the last classification by the Eli Commission that was published in 2010 for the work that has been done in the past from 2005 to 2009. And in this new classification, importantly, neonatal seizures are no longer regarded as a separate entity, and they should then be classified with the same scheme we have for children and adults. And another important thing is that electrographically documented neonatal seizure, with or without clinical manifestation, they actually represent the most accurate and current concept of neonatal seizures. So when we do a diagnosis of a neurological problem of an epilepsy, we start from the initial seizure type. Then we consider the age at onset, the EEG features, examination findings. If we can add MRI findings. It's important for the diagnosis of an epilepsy syndrome, the developmental course, and possibly the addition to other seizure type in the course, the gene, if we can find the gene, and then we have the complete diagnosis. In the neonates, we miss several pieces of the puzzle, and so the diagnosis can be difficult, especially if this first piece of the puzzle is wrong, if our initial seizure type is not well defined and characterized. This is a newborn 2 days old. Starting to have this behavior from the first hours of life. You can see the EEG going on with a slow, disorganized background pattern and several seizure discharges on one side and another side of the brain. But what I want to show you is this clinical manifestation. So again, you are calling me in the middle of the night, and you have this child that just came out, that just was delivered and started with this clinical manifestation. So you bring him to the neonatal intensive care unit, and you put the EEG on. You have a disorganized low tracing with multifocal epileptiform abnormalities, and he has something, right? And jitteriness? No. Okay, that's just a good point. And erratic twitching myoclonic jerks. Okay? Mainly we now took the face because I think this was very, very important, but you see that he has this twitching of the eyes, one time the eyes, the other time the other eyes, and the rest of the face. This is the EEG of the baby, and this was one seizure, but you can see that he has multiple epileptiform abnormalities over a very slow and disturbed EEG background. This is the reduction of the epileptiform abnormalities few minutes after the infusion of pyridoxine IV, and this is 3 hours after pyridoxine IV infusion. Pyridoxine dependency is the prototype of a severe but eminently treatable condition that no clinician wants to miss. You cannot miss pyridoxine dependency. You really can't. Why you can't? Because seizures are prominent in presentation, so you have the clinical part. Pyridoxine dependency is eminently treatable, and the prognosis of this baby is clearly linked to the early diagnosis and treatment. Pyridoxine-dependent epilepsy is an autosomic recessive disorder that has been recently discovered to be associated with the antiquitine gene ALDH7A1 on chromosome 5. Neonatal seizures are very, very early onset, the first days of life, most of the time, the first hours, and some of them, for some of them, mothers report that they probably had seizures while in the womb, because when they see the baby having seizure, they say, I think I felt the same thing when I was pregnant. They require lifelong pyridoxine supplementation, and prognosis again is linked to early diagnosis and treatment. Misdiagnosis can lead to death. What's about the clinical presentation? Besides the seizures, they are usually very irritable. They are encephalopathic. Very commonly, they have GI symptoms. They have vomiting, unexplained vomiting. But another very important thing is that this is a very nice paper published by Baxter in 1999 showing that in a huge series that 1/3 of neonatal cases were initially diagnosed with HIE. This is again another problem. I think we can ameliorate. Not every baby with a neurological problem in the NICU has hypoxic ischemic encephalopathy, but most of them, they are labeled as hypoxic ischemic encephalopathy. And the bad part of it is that it's better to say this child has a neurological problem of unknown cause, because people don't stop to think, people don't stop to search. But if you put a label hypoxic ischemic encephalopathy, people stop to think. People won't search anymore. And this is really bad for the diagnosis. So hypoxic ischemic encephalopathy is a very precise condition that needs to have some criteria to be defined. And do not start thinking that the APGAR, sometimes I say, but this is hypoxic ischemic, you say hypoxic ischemic encephalopathy, but this baby had, 7, 8, 9, and they said, oh, don't believe the obstetrician. I actually believe the obstetrician. So if it doesn't fulfill the criteria for hypoxia ischemia, then it's probably another thing. Some baby, they can have atypical presentation with late onset presentation in the first months of life, and in some babies, an initial control of seizure with antiepileptic drugs can be achieved, but then they develop intractable seizure. So think about it, especially if you don't have a cause. Seizure semiology, what kind of seizure type? Main seizure type is myoclonic seizures. Remember that myoclonic seizure rhymes with metabolic disorder. Every time you have myoclonic seizure, especially erratic myoclonic seizure, which is different from clonic seizure, think about a metabolic disorder. Other seizure type can appear also in this condition. The EEG features are also important. You don't have the focal discharges or the focal asymmetry that we saw in the stroke. You don't have the bar suppression pattern that you can have in hypoxic ischemic encephalopathy. You have a diffuse low wave patterns. Epileptiform abnormalities are usually multifocal. If you wait too long, these babies can go into a bar suppression pattern, but very nicely after B6 administration, you have a disappearance of spikes and reduction of the slow waves and no more seizures. So if you think about pyridoxine dependency, and you might want to think about it early in your protocol, trial with pyridoxine should be done. We use 300 milligram IV. during EEG monitoring is better because you can really see the changes right away. You should do that in the NICU, in the intensive care unit, because especially if you infuse pyridoxine dependency IV, you can have adverse events such as breathing depression, lethargy, and hypotonia. Once you have the first results on the EEG monitoring, you might want to discontinue all the antiepileptic drugs and continue the maintenance with vitamin B6, 50 to 150 milligram per day in 2 doses. And this is again Baxter that was suggesting that while 5 milligram per kilo per day may control seizure, it's possible that an higher dose may improve the subsequent development. So before, in the past, let's say 10 years ago, 15 years ago, when we had the suspicion of pyridoxine dependency, we were giving pyridoxine, good results, and then to prove it, we had to stop pyridoxine and wait for the seizure to come back, and then give pyridoxine again. But then biochemistry helped us because this is the vitamin B6 pattern, and you can see that if you have a mutation of the antiquitine gene, then your pyridoxal phosphates cannot be transformed, and you have an accumulation of the pipecolic acid. And this is very, very important because this elevated pipecolic acid is both in plasma and CSF, and this is really a biomarker of pyridoxine-dependent epilepsy because it persists despite years of pyridoxine treatment. So before the genetic testing was available, and because the genetic testing can take months to be done, detection of pipecolic acid is really important because precludes the need for a diagnostic pyridoxine withdrawal to confirm the diagnosis. This is a very nice paper that was published on Brain little time ago, and was by the group of UCL and Great Ormond Street hospitals, and they presented 37 individuals taken out of a huge number of individuals with pyridoxine-dependent epilepsy associated with antiquitine gene mutation. And the important thing of this paper is that they show how the clinical diagnosis of pyridoxine-dependent epilepsy can be challenging. Some baby may have some response, as I told you, of antiepileptic drugs. In infants with multi-system pathology, the response might not be instant and obvious. So you might want, if you see something on the EEG in the beginning, or if you decide not to give pyridoxine IV, but to give pyridoxine by mouth, then you might want to wait to see if you have any changes in 2 days, 3 days. Structural brain abnormalities can coexist. And so trials of pyridoxine should be done properly, minimum 72 hours with clinical and EEG monitoring, and if there is any sign of improvement, pyridoxine should be continued. This is a vitamin, is not really harmful and can be very, very helpful. When should we think about it? Seizures of unknown etiology in a previously normal infant without an abnormal gestation or perinatal history. In 2 words, unexplained early onset seizures. Long-lasting focal or unilateral seizures, signs of encephalopathy, irritability, restlessness, crying, vomiting that precede the seizure, a history of severe epilepsy in a sibling, often leading to death during status epilepticus. We have children that came with a positive family history, and the diagnosis for the dead brother was, again, hypoxic ischemic encephalopathy. And importantly, is parental consanguinity. So history is also very important, and I think I want to underline this in the NICU. For us as a child neurologist, it's easier because you sit in front of the parents and your child, and you can ask the family history. But for you, the baby might come and maybe transfer from another hospital, and you don't have the parents, or you have only the father usually not helpful, and you don't have the mother, and you don't have the information you need. So you really want to call them and talk to them and try to get the most information as possible. Those are the vitamin-responsive neonatal epilepsies you don't want to miss. I cannot show you all, but remember that if pyridoxine fail and you still think about them, you should try folinic acid. If folinic acid fail, you might want to try folic acid. Pyridoxal 5-phosphate is also a responsive epilepsy recently found. This is important because all three present with anti-epileptic drug-resistant neonatal seizure, and the early recognition really can improve the prognosis in these babies. So pyridoxine, pyridoxal 5-phosphate, and folinic acid should be considered as treatments when suspected vitamin-responsive epilepsies in the newborn. What should you do if you suspect them? So first of all, you can take some samples, CSF, for neurotransmitter metabolites, and you might want to look as well, and we will see it, non-ketotic hyperglycemia. But you want to take them and maybe store them. Blood should be checked for amino acid, pipecolic acid, and ASA. And this is, again, important because they present with this type of myoclonic seizure, so you think about metabolic disorders. Urine should be taken and checked for vanillic acid and stocked, and also a DNA should be banked for future confirmatory testing of a genetic disorder. The protocol is to try, the trials include pyridoxine from 100, several studies from 100 to 500 milligram IV, possibly with continuous EEG monitoring. Pyridoxal 5-phosphate, those are the doses. You will have all our, I forgot to tell you yesterday, all our lecture will be available at the front desk for you to take, and of course will be on the IPOKRaTES website. And folinic acid, those are the doses for folinic acid trial. If the disease is confirmed, then you go on with the chronic therapy for confirmed pyridoxine-dependent epilepsy. Those are the doses. Pyridoxine should be continued, probably at higher dose that we were used to do in the past. And it seems that can be useful to add folinic acid even to pyridoxine-dependent epilepsy because genetically those are allelic. And so this can be helpful for the long-term prognosis. This is another baby, and you can see from the clinical point of view, this baby is not doing very well. He's 4 days of life and has been doing this from the very first hours of life. You can see the EEG on the back. I will show you better on the slides, but you can recognize clearly this pattern, which is a bar suppression pattern. And if you want to take the time to look at the baby carefully, then you might want to tell me what do you see in terms of semiology of clinical manifestation. So baby doesn't do much, right? He doesn't have spontaneous movement. So he has multifocal, erratic, small amplitude myoclonic jerks. And in order to see it, because those are quite continuously present during the day, you really want to watch him and stay close by, and possibly you want to do a polygraphic EEG recording. Now we are entering the epilepsies and epilepsy syndromes. And this is where it's important to do continuous EEG monitoring, but it's also important to have a precise polygraphic EEG recording. You don't need to monitor this child for days, because this is what he will do day by day, but you want to do a good recording for a couple of hours with the polygraphic channels to see what type of seizure this baby has. So this is a little bit what we gain with long-term monitoring. We gain a view of everything that happened for hours and days, and this is important. let's say for hypoxic ischemic encephalopathy or stroke, because you can monitor babies in the acute phase. For neonatal onset epilepsies, by doing that only, we lose the characterization of seizure that we gain with a recording that can last 2 or 3 hours, but we have the technician there that can do a lot of testing and that can put polygraphic electrodes. So this is the EEG of this baby, and this is a polygraphic EEG recording with chest respiration and right hand and left hand electrodes. And you can see the small amplitude myoclonic jerks that we were seeing. And if you don't do a polygraphic recording, those jerks are very difficult to capture on a regular EEG. And you see the burst suppression pattern. So you have this burst of activity intermixed with period of almost inactivity of the brain. You can also see how during the burst is what is going on in the baby's brain is when during the burst he can breathe. Those are small gasps, but you see that what has to happen happens during the burst, and nothing really happens during the suppression period. And this is again, it's the same EEG of this baby. You see the small erratic multifocal myoclonic jerking, and here we only put hands, but if you put other electrodes, you will see them appearing everywhere in the body. This baby had a non-ketotic hyperglycemia, and clinically you can define this form of epilepsy in the neonatal period, early myoclonic encephalopathy. Early myoclonic encephalopathy onset is in the neonatal period, usually within the first hours of life. Babies are hypotonic and poorly responsive, is associated with a burst suppression EEG pattern. The seizure type is segmental and erratic myoclonus, sometimes can be massive, axial massive, affecting face and limbs. These babies have virtual absence of neurological development. Most medication are not effective. Recently, the group of the Bambino Gesù published some cases, but late in the diagnosis, in which ketogenic diet improved the seizures, but not really the developmental outcome. This is the worst epilepsy you can have in your whole life, and I think it's very important to diagnose because you can have familial recurrence. And if you had a child with this condition, you don't want to have two. The reason why you have a familial recurrence is because the underlying disorder is metabolic in most of the cases, non-ketotic hyperglycemia, methylmalonic or propionic acidemia, pyridoxine deficiency. MRI is usually normal. MRS is now in non-ketotic hyperglycemia showing the peak of glycine, and in some cases you cannot find a metabolic disorder. So now I have another newborn for you. 13 days old. Let's start from something you have seen already. So the EEG pattern is a burst suppression. But what about these movements? So what about these movements? Seizure type, those are seizures. Let's move on. So seizure type. It's too prolonged to be myoclonic jerks. Those are myoclonic jerks. Very close. Those are tonic spasms. And I will show you those are spasms in which the tonic phase is sustained compared to infantile spasms. Sorry. So those are tonic spasms. The tonic component of the arm extension and adduction is sustained compared with infantile spasms. And this baby had an asymmetric tonic spasm, which is seen almost exclusively in patients with focal brain lesion. So different. Myoclonic jerks rhyme with metabolic disorder. Tonic spasm, especially asymmetric tonic spasm, rhymes with structural abnormalities. I'm sorry. So those, just to show you the difference, those are infantile spasms in a baby with a tuberous sclerosis, 3 months old. So there is a brief muscular axial contraction that involves the trunk and the limbs, can be inflection or extension. But if you remember our baby, the tonic phase was sustained. So that's why we use polygraphic recording, and this has been very important in the past 20 years to define this syndrome. We use polygraphic recording, and we can show that this is a myoclonic jerk, which is a very rapid shock-like muscle contraction that lasts very, very shortly, less than 200 milliseconds, and the Eeg counterpart is a diffuse spike wave complex. Whether atonic seizures, that what we see in Lennox-Gastaut, for example, is a prolonged muscle contraction of growing intensity with the Eeg showing a diffuse recruiting fast activity. So this is atonic seizure. See how does it appear? Right deltoid, left deltoid, so you see an increase of the tonic contraction. The spasm is a muscle contraction that lasts 1 to 2 seconds, reaches a peak, and more slowly compared to a myoclonic jerk, but more rapidly than atonic seizures. And the tonic spasm is similar to spasm, but after the first contraction, there is a sustained tonic phase. And this is actually the Eeg of the baby I show you. So you can see that there is an asymmetry in the spasm, because on the right deltoid you have a more pronounced contraction. The contraction is prolonged at the end, that's why it's a tonic spasm, and is less pronounced on the left side. And if you look at the Eeg, we have again a burst suppression, but the bursts are more pronounced over the left side, and this is very well combines with more pronounced contraction over the right deltoid. So asymmetric burst suppression, asymmetric tonic spasms. This baby had a left-sided hemimegalencephaly. And epilepsy diagnosis is Ohtahara syndrome. Ohtahara syndrome, the onset is within the first days of life. Main seizure pattern is tonic spasms. The Eeg pattern is the same than early onset myoclonic epilepsy as a burst suppression. There is a severe psychomotor retardation and the prognosis is poor. But especially if you have a structural abnormality, there are treatment options. Vigabatrin may improve the condition and surgery can be useful. The etiology is hemimegalencephaly, focal cortical dysgenesis in general, and the genetics. They are now finding as responsible for those cases in which there is no structural abnormalities. So I hope I convince you that you won't load this baby with phenobarbital. You won't put in your chart only the diagnosis of neonatal seizure, because this is really not helpful. This is a home video taken by a mother. This baby is 8 weeks old. So here is atonic spasm, as I showed you before, and in this case is followed by a focal seizure with eye deviation over the left side. And then you will see a series of tonic spasms. That seems quite obvious now that I show you on the video, now that the mother made the home video, but was not actually early in the history, in the course of this baby. This was another tonic spasm. And this is what the mom said. We took our baby to the pediatrician and a special colic clinic to determine what was wrong with him for the first 8 weeks of his life. He was jackknifing and rolling his eyes. Our doctors asked all along if he turned blue, but he never did. And just because your baby doesn't turn blue doesn't mean he's not having seizures. We filmed our baby out of desperation and finally got some attention. He was determined that he was having infantile spasms, but no sign of the so-called classic seizures, and God knows what are the classic seizures. And after an MRI, the baby received the diagnosis of hemimegalencephaly. So what I show you is the two neonatal onset epileptic encephalopathy with suppression burst. One is Otara syndrome, and the other one is early myoclonic encephalopathy. Both of them are burst suppression, but more important is the type of seizure. That's why it's important for you to make the precise characterization, myoclonic versus tonic spasms, because these will influence the workup and the treatment. Not everybody can do everything very, very early, which is metabolic search and MRI, so you want to choose where you want to go in your workup, and you want to be guided by the seizure type and, of course, the EEG. And why this is important? Because we know that some anti-epileptic drug can worsen actually the situation, and especially carbamazepine or vigabatrin, which is good for Otara syndrome and tonic seizure, can induce status epilepticus, myoclonic status epilepticus. And this is a paper published by a Turkish group showing 2 cases in which vigabatrin was given in babies with early myoclonic encephalopathy associated with non-ketotic hyperglycinemia, and actually caused rapidly progressive deterioration and death of these babies. And why this happened? Because vigabatrin, the substance is gamma-vinyl GABA, and works by elevating the GABA concentration in the brain. And both at the end of the first month of life, this baby were first month of life, they had hyperglycinemia, and glycine is the other inhibitory neurotransmitter of the brain. So if you increase the inhibition in this brain, then as in this case, they had sleepiness, respiratory failure, and ultimately they died. Otara syndrome and early myoclonic encephalopathy are defined as a neonatal encephalopathy with suppression burst. So this is a new concept that has been determined by the classification on seizure and terminology published in 2001. And this was a new concept, or this is a new concept maybe for you. An epileptic encephalopathy is a condition in which the epileptiform abnormalities themselves are believed to contribute to the progressive disturbance in cerebral function. It means that even if your spasm disappear, even if you infuse something like benzodiazepine or your myoclonic jerk calm down, your EEG is still a burst suppression, and you are not improving the condition of the baby, because the EEG abnormalities are important contribution to the disturbance in cerebral function. Just 2 words about the burst suppression pattern. So this is characterized by, as I show you, bursts of high voltage activity intermixed with very low voltage marked background attenuation. And this pattern is persistent throughout awake, and the sleep state is unreactive and unaltered by exogenous stimuli. So this is the burst suppression during awake state. All these are muscular artifacts. This is the oculogram, this is the thoracic respiration, nasal respiration, and EKG. And you can see that the pattern doesn't change, only the muscular artifact and the oculogram changes during the sleep state. So you know that a discharge corresponds to a group of neurons firing. Altogether, you have the eye spikes, and then you have the seizures, right? So this is the pathophysiology of seizures and seizure discharges. Do you know what is the pathophysiology of burst suppression? You heard a lot of burst suppression during these days, but how comes that the brain does this pattern of a burst, pseudo-periodic pattern, of a burst and then a suppression, a burst and then a suppression, and then another burst and then another suppression? Where does it come from? So why the brain does this? If a group of neurons fire together, they give these big spikes, right? Because these are all together and the spikes are high amplitude. This is the seizure. So why the bar suppression has a bad prognosis? So what is the bar suppression, pathophysiologically speaking? Neurophysiologically speaking, what is a bar suppression? Any volunteer? What is a bar suppression? Why the brain starts to do burst and suppression, unchangedly for hours and hours and hours? Or imagine hypoxic ischemic encephalopathy. Why bar suppression is bad? What does it mean, bar suppression? You can have bar suppression pattern induced by barbiturate anesthesia. You know, some babies and also adults that are on brain monitoring and they wait until they say, the anesthesiologist says, until it goes into bar suppression. Hypoxic ischemic encephalopathy in the early stages can have a burst suppression. Those are usually transient and EEG changes. So if you stop anesthesia, your brain activity comes back. But in some cases, like deep brain tumors, severe congenital metabolic disorder, and severe brain malformation, your burst suppression is actually persistent. Does it help?
Because it means that you have no cortical electrical activity, you just have a basic rhythm. Not a basic, more a brainstem or a ganglion rhythm.
Exactly. So this means that your cortex is not functioning and it takes passively the burst that comes from the thalamic neurons, that if you have a brain injury, if you have a brain malformation, if you have an important and severe metabolic disorder, then your cortex will get so sick that cannot function anymore. But 30-40% of thalamic neurons that have intrinsic pacemaking properties, that's why you have this pseudo-periodic pattern. They continue firing while the cortex is silent. And so the burst you see comes from volleys of these thalamocortical neurons that generate this burst over a cortical background that is depressed and can be totally flat. So this is why, and this is a very nice work on anesthetized cat that started all this, published in 1994 by Steria, that did a wonderful work on neurophysiology, basic neurophysiology. And so this is why your prognosis is poor, because it means that your cortex is very, very, very sick, is actually not functioning anymore. So neonates, they can have more than a seizure type. And I told you that we will make it difficult today. Even focal clonic seizure, which is the type most likely to occur alone, can be mixed with other seizure type. And so with reviewing seizures with video EEG, you can really document the various kinds of seizure that can be present in the same baby. So this is a baby, 15 days old, that started to have seizures in the first days of life, was treated with phenobarbital, seizure remitted for a week, and then presented again with seizure of this type. The baby is different from the baby that I showed you. It's quite well. It doesn't have IV line. He's eating by himself. The only problem is after that he went into status epilepticus and went from the neurology unit to the intensive care unit. And this is the seizure type. So here you have a discharge that starts over the left central region. The baby started with atonic posturing of the right leg, then clonic phase over the right leg and right arm. And before that, the baby had an apnea and started to be a little bit red. So this is a focal seizures that is characterized by autonomic symptoms, tonic phase, and then finally a clonic phase. But what was interesting in this baby is that if you continue to go on in the same recording, and I'm not interrupting, the first seizure stop, we see that he had a discharge over the right central region, over the left central region, which correspond to the seizure lateralized over the right side. And after a few seconds after the first seizure stopped, you will see an ictal discharge that is organizing here over the right central region, and the baby will have the same thing. So we'll have a tonic posturing, autonomic dysfunction, and he will become red and stop breathing. Here is the tonic phase that continues, and then will be followed by a clonic phase. So this is a very nice mixed seizure type. And by showing this, you could say, who cares? I care, because this is the typical seizure type of the benign familial neonatal seizures, which are focal seizure, but they involve one side of the brain and the other side of the brain, and they are actually expression of a diffuse disorder, which is a potassium channel mutation. So this baby was hospitalized at the Bambino Gesù Children's Hospital, came from the south of Italy, and we tried several medications. He was infused with phenobarbital, phenytoin, and then the father came and he said, actually, I was hospitalized here. Oh, sorry, this is the Eeg. Here you have the tonic phase over the right deltoid. This is the first seizure, followed by the clonic phase, and ending with the clonic phase. And this is the second seizure, starting right after the first one, and you have the tonic phase over the opposite arm, and then followed by the clonic phase. So the father said, I was hospitalized here, so we took the chart, and the diagnosis was neonatal seizures. So this was very, very important, because we treated this baby with low-dose carbamazepine. Seizures never recurred. This was back in, I don't know. I don't want to remember how back was it. This was back in 2002. The child is 10 years now and never had any seizures. He's very smart and a very nice baby. So when you have seen the first one, this might be helpful when you happen to see the second one, because you recognize it. And this is a baby with the same disorder, benign familial neonatal seizure, KCNQ2 mutation, that we observed at the Children's Hospital in San Francisco. And you can see that the sequence is quite the same. He has a focal tonic posturing, and you will see that is followed by a clonic phase. The tonic posturing is quite prolonged. The baby will have apnea. Seizures are very short, but can be very frequent. The baby is doing quite well. He's not intubated, has a good tonus, global tonus. So why this is helpful to make the diagnosis? These are the family we published a while ago, and we did electrophysiology on those babies. But interestingly, this is the mother that had the neonatal seizure in day of life 2, got a CT scan, an LP that was normal, but she was diagnosed with meningitis, and she got double therapy with phenobarbital and phenytoin until age of 6 years. This was the proband, the first girl. We had, again, seizure on day of life 2. She got an MRI, an LP, an extensive metabolic screening. She was hospitalized for 15 days, and she was treated with phenobarbital for a year. But her sister, after we knew about the mutation and we realized that this was a benign familial neonatal seizure, she was hospitalized for 24 hours. She had only an ultrasound, and she was treated with oral carbamazepine and never had seizures. So I think this is important for families, this is important for children to make the right diagnosis and to give the appropriate treatment. We were very happy because about the benign familial neonatal seizure and KCNQ2, KCNQ3 mutation associated with that until beginning of this year, when this group of from also the Netherlands and Belgium, they found out that actually you can have KCNQ2 mutation in a different and severe form of epilepsies that starts in the neonatal period, and they call this KCNQ2 encephalopathy. What is very interesting is that this baby in the beginning, they have the same type of seizure, they do tonic seizures followed by clonic components, but they have a bar-suppressed EEG. And the prognosis is very bad, they have intractable seizure, and seizure remits at the end of the first years, but these babies are tetraplegic with a very important and severe cognitive deficit. So you have benign familial neonatal seizure and KCNQ2 encephalopathy. Both of them have tonic seizure accompanied by motor and autonomic features. Both of them have mutation in KCNQ2 gene, but one has a normal interictal EEG, which is benign familial neonatal seizure. The other one, EEG, is a bar suppression pattern. The first one has a favorable seizure outcome. The second one developed treatment-resistant epilepsy, although seizure remits at the end of the first year. And this is very interesting because this is common to the two disorders, very, very acute and important seizure in the neonatal period, then they do well at the end of the first year, normal developmental outcome and poor developmental outcome. So in patients with KCNQ2 mutation, the EEG pattern correlates better with prognosis than did the molecular genetic findings, and I take the chance to tell you what I think about genetic findings. I work with genetic, I work with rare diseases, but the assumption that a genetic disorder is equal a disease is absolutely false. So you have to make your clinical diagnosis, and then you ask for genetic confirmation. So some pattern EEG have different seizure type, and this is important for diagnosis. Some babies have same seizure type but different pattern EEG, as in KCNQ2 encephalopathy and benign familial neonatal seizure, and mutation, just to make things easier, in one gene can be linked to severe and benign epilepsy. I have a last thing to show you about seizure, and this is a new recognized epilepsy syndrome, recognized in the last classification of 2010, actually described by Gian Gennaro Coppola and Olivier Dulac in Paris in 1995. The onset is the first 6 months, but by the time we are discovering new cases, we found that in 1/2 of cases, the onset is in the first month of life, and some of them, they have seizures in the very first days of life. So you might encounter one of those. The typical seizure type are multifocal partial seizures that really migrate from one hemisphere to another. They are absolutely intractable. There is a neurological deterioration or arrest and the decline of head circumference percentile. And this is one EEG, continuous EEG, and you can see one seizure here over the left hemisphere, and then the EEG goes on and the seizure moves over the frontal region, but there is another seizure starting independently over the frontal region of the right hemisphere. And now you have two seizures going together in both hemispheres, and then the one over the left is finishing, the one over the right is continued, but migrates from the frontal region going more posteriorly on the temporal region. And now there is no more seizure over the left side, over the right side, but the seizures came back over the left hemisphere. So seizures really migrate. This is the MRI of one of our patients. 5 months, he started at 4 months. 5 months after seizure onset, and 11 months after seizure onset. This is a very, very severe epileptic disorder. We recently, 15 days ago, thanks to the work of Rima Nabout from Necker Enfants Malades, we discovered that another potassium channel mutation is linked and causes malignant partial seizures of infancy. So the challenge of treatment, new strategies for treating seizures in the neonates. We know that from this very seminal work published in 1993 by Painter in New England Journal of Medicine that phenobarbital and phenytoin actually works really only in 50% of the neonates. They were introduced in 1914 and respectively in 1938, and so far there are really almost no drugs that are approved for the neonates. So there was a very nice Cochrane review in 2004 saying that there is actually little evidence even to support the use of any of the anti-epileptic drugs currently used in the neonatal period. We don't know how do they work. We don't know if really they work. There is a big heterogeneity in a seizure definition, and of course, if you try phenobarbital in early myoclonic encephalopathy and you say it doesn't work, doesn't make any sense. If you try phenobarbital in Ohtara syndrome or phenytoin in Ohtara syndrome, will never work. And so you cannot make your point if you do not define precise subgroup of babies with seizures. And as I say, we should move from the classification of neonatal seizure to the classification of newborns with seizures. There are no data available on whether controlling neonatal seizure has a measurable impact on the most important outcome, particularly on mortality and neurodevelopmental impairment. Why is it difficult to develop new treatment in the neonates? First of all, because there is lack of continuous brain monitoring of high-risk infants. If you cannot quantify seizures, you don't know if seizures are good or seizures are bad, if you have difficulty even in recognizing them. You need to be sure that your treatment is good, because if you do evaluate the efficacy of phenobarbital without EEG, you might think, okay, it works, but then you have the uncoupling and you have a lot of seizures still going on after the clinical part disappears. In neonates, it's impossible to conduct a placebo-controlled trial. There is a need of a prospective randomized and controlled trial, and it's very important to differentiate acute seizures from neonatal onset epilepsies. So this is something that might cause some problem with Jerome when he said maybe we should use medication to be prophylactic. There are now several studies in animals showing that in the immature brain, medication that work on by enhancing GABA receptors that we know they are excitatory may actually produce apoptosis of neurons. There is one thing that is important, and Jerome already underlined that might be a difference of these effects on a sick brain compared to a normal brain. So we could say at least that, of course, we use phenobarbital if needed. Try not to use phenobarbital if you are not sure that the baby is having seizures, because the impact of phenobarbital or those anti-epileptic drugs can be different in a healthy brain compared to a sick brain. I showed you the picture yesterday. So why phenobarbital and benzodiazepine might not work well in the neonate compared with the adult brain is because GABA is depolarizing and not hyperpolarizing as it happened in the older child and the adult. So what happened in the immature neurons, you have an NK-CC1 receptor that is overexpressed both in term human and immature rats, and you have a KCC2 that is underexpressed in the newborn brain. In the mature neurons, your NK-CC1 will be underexpressed and there is a maturation of KCC2. What is the difference? The difference is that in immature neurons, you will have an accumulation of chlorides, and these will increase the ictal activity, the excitation in this brain. So what happens is that this upregulation switches the polarity of GABA action toward the excitation. So this is very important, and this is probably the reason of this switch into excitation. These findings suggested the potential use of chloride transporter inhibitors for neonatal seizures. So bumetanide is a diuretic that works as an NK-CC1 inhibitor. Is a FDA-approved diuretics that was used previously in neonatal population, and this makes things easier in terms of approval. What does it do? Basically, it turns immature neurons into mature neurons, restores gradient, allow for hyperpolarization, and allow for GABA to be inhibitory, and so people start to say, oh, this might be synergistic with phenobarbital, because if GABA is inhibitory and phenobarbital enhances GABA, then maybe bumetanide will help phenobarbital. And this is a study on Annals of Neurology that started all this, showing that the combination of phenobarbital and bumetanide is significantly more effective than phenobarbital alone on seizure occurrence, frequency, and duration. Although I must say this is an in vitro model of neonatal seizure, but this was an important concept. And so clinical trials started, and there is one in Europe. It's called NEMO, and Linda De Vries is one of the main participant center and responsible of work packages. The important thing is that they only take a subgroup of newborn, which are neonates with HIE. All of them, they need to be continuous monitored with EEG as the gold standard method for seizure diagnosis and for seizure treatment efficacy diagnosis. Another medication that you may know, and we are all using it now in our NICU, is Levity Racetam. Has a good efficacy and tolerability in children and young infants. It's good in the NICU because there is no hepatic elimination, so you can use it even if you have multi-system problem. There are no interactions with other anti-epileptic drugs, and IV form is available. Topamax, topiramate, I won't talk about this because it's only available in oral form and is not ready to be used in the NICU, especially for acute seizures. There is increasing experience in the neonates, and there are really very mild side effects. And this is very, very recent. So we start to think about, potassium channel are not only responsible to a benign form of neonatal seizure, but can also lead to neonatal KCNQ2 encephalopathy. And now we found another potassium channel responsible for the very severe form of migrating partial seizure in infancy. So we start to think about the potential use of neuronal potassium channel openers for neonatal seizures. So potassium channels are actually very, very important in the neonatal brain because they represent the main form of inhibition in the neonatal brain. In a time where GABA is excitatory, we know that NKCC1 is overexpressed, but here are our potassium channel that bring the potassium out of the cell, restore the hyperpolarization, and help the inhibition in the neonatal brain. And if those are so in a difficult equilibrium, in a difficult balancing the inhibition in the neonatal brain, if those are impaired, then we have seizures in the neonates. And those are early seizures, both in migrating partial seizure in infancy, neonatal, benign familial neonatal seizure, and KCNQ2 encephalopathy. This is a very, very nice review that has been published a week ago by Greg Holmes and Ross Scott from Dartmouth, opening up the potassium door in neonatal seizure. And the base is that potassium channel provide one of the few sources of inhibition in the brain that is heavily weighted toward excitation, and they should be considered as a target for treating seizures and epilepsy in the neonatal period. There is a sense, so you open the potassium channel and you go toward the hyperpolarizing direction, and if you block the potassium channel, then the cell will depolarize. What are these potassium channel openers? Mainly retigabine, which we use in child epileptology, was approved in 2011 as a treatment for refractory partial seizure in adults. We use it in children. Most of the anti-epileptic drug we use in children are off-label, actually. The second one is flupirtine. They are both analog, and this is a very nice paper published in 2009, showing then for a neonatal seizure, flupirtine is more effective than phenobarbital and diazepam in the animal model of Caini casein and fluorotyl neonatal seizures in rats. So the key point is that this is my last talk on seizures. Seizure recognition remains for us the foremost challenge to overcome, especially in the NICU. We need continuous video EEG monitoring. Some situations need polygraphic EEG recording to go to the correct interpretation of the clinical manifestation and to the right diagnosis and treatment. Please consider seizures in their overall context. Don't put the diagnosis neonatal seizure. It's not helpful for the baby, and it's not helpful if you have the baby as a child neurology afterwards and you have to deal with this diagnosis. Treatment should be tailored, and I like protocols, but only for subgroup of babies, such as hypoxic ischemia or stroke. And I take the chance again to thank the group, Donna Ferriero, Dave Rowich, Jim Barkovich of the Neonatal Intensive Care Nursery, the whole group of the Bambino Gesù Children's Hospital Neurology Division, Rima Nabut, who designed the study that led us to discover the potassium channel defect in migrating partial seizure in infancy. And I want to thank particularly the EEG technician of the Bambino Gesù Children's Hospital that have been performing wonderful polygraphic video EEG recording in neonates for the past 20 years. Thank you very much. Any question?
How many of these early onset seizure do start as an onset within the first 6 hours of life? I mean, how many of them are we going to cool?
So pyridoxine dependency for sure, early myoclonic encephalopathy for sure, tonic spasm, they appear in the first days. But the metabolic disorders can appear very, very onset, and I think this is the big challenge for hypothermia. We had some of these cases in San Francisco, and we had to redirect and to stop the cooling because we realized that this baby were having something else. So I would say that metabolic disorders are the biggest challenge for. But those babies, usually they are not born with low APGAR, but they can have acidosis. Please.
I have a question about the pyridoxine deficiency. You stated that sometimes it's confused with the HIE. And you also said that sometimes they react to anti-epileptic drugs and sometimes they are resistant. Now, I wonder after how many drugs you would consider the seizures as anti-epileptic drug resistant, because you can give 1, 2, 3, 4 different sorts of drugs, and especially because this is a treatable disorder, but the incidence of HIE is so much higher than the incidence of pyridoxine deficiency. So how are we going to do that in the
This is a
daily
very,
practice?
very important point, and you are provoking me. So how do you do
I don't
it?
mean to.
How do you do it? The HIE that Baxter show is a false diagnosis. So babies were labeled as HIE because when you don't know about what the baby can have, you put the label HIE. So let's take a situation. So you have a baby with normal APGAR that started to have this myoclonic type of seizure. So first you think, oh, myoclonic, erratic myoclonic jerks, face doing this might be metabolic. And then if you are not sure it's 2 o'clock in the night, then you can try phenobarbital. I'm not saying no, and phenobarbital doesn't work, or the baby is very much sedated, and once your load is finished, the baby start again with the myoclonic jerks, and then maybe you do an ultrasound, and your ultrasound is normal, and then you start to get more information, and by then you arrive early in the morning, and you talk to the parents, and maybe they say that there is a brother that died or a sister that died with such a condition. And so you start to say, maybe I shouldn't go through phenytoin, Levity Racetam, and so on. Why we don't try pyridoxine? And the same is with how can we pick up babies, children or infants with pyridoxine-dependent epilepsy? We pick them up because you start to think, why this baby is seizing? MRI is quite normal, there is no history, and is still seizing. So it's something that is unexplained. And then you say, maybe I should try pyridoxine. So this is a little bit how we should proceed. So we should look at our baby seizing and say, who is this baby? Who is this baby? Is a normal baby or is a baby with hypoxic ischemic encephalopathy? If you have a baby with a clear inclusion criteria, precise inclusion criteria for hypothermia, then you go with your phenobarbital, phenytoin. I know Linda used a lot of lidocaine. We have no experience with that, and midazolam. And I think everybody has his own sequencing. And people were asking me yesterday, do you start with phenobarbital? Someone else start with phenytoin? I start with phenobarbital. I don't think that is, I mean, it's more how you manage your drugs. But the most important thing is not stop thinking. So if by the morning you start to say, I'm not sure that this baby is really hypoxic ischemic encephalopathy, and then you move on and you say, let's try pyridoxine.
Thank you, Roberta, for a lot of very important information. I just want to disagree with you on one little point. You know, I like to do ultrasound, so we actually have made a diagnosis, or at least we're highly suspicious of non-ketotic hypoglycemia by doing an ultrasound and finding a kind of dysplastic or hypoplastic corpus callosum. And I think that this is quite a common marker in this disorder. And also when you do the MRI, in these children you confirm your hypoplasia of your corpus callosum, but also these children lack myelination in the posterior limb at term, and they have some white matter changes. So I think we had a few babies who turned up with hiccups and burst suppression and also had a corpus callosum problem on early ultrasound, and it helps to make the diagnosis, or at least suspect
can direct
the diagnosis.
you. No, of course.
And one more
Oh,
thing?
no, it's not a disagreement. I think it depends very much how you are experienced with your tools. So I can use EEG and polygraphic EEG recording because this is my work. But, and honestly, I would say that in San Francisco, there is no such an experience for ultrasounds. And you need to be very good for ultrasounds. And so I think that everybody should know, and I thank you for pointing this out, because everybody should know what are the features and then use their own tools to confirm a clinical diagnosis. But most of the cases, I think the diagnosis is missed because you don't think about it. But if you think about it, then you go your ultrasound and you look at the corpus callosum and things move on, and I might do my EEG with polygraphic recording, but we think about it. Any other question? So we are back at 1:15.
So the one of you who gave the name for lunch, you can follow Paola, and yes, and together with faculty.